Imagine a 2-year-old child. They are, just learning to walk, stringing together their first sentences, really just discovering the world.
Right.
Now, I want you to imagine that deep inside their coronary arteries, atherosclerotic lesions, the very first, cellular seeds of a heart attack are actually already forming.
It's a terrifying thought, honestly.
It really is. Today, we aren't just looking at adult heart disease, we are diving into dyslipidemia. It's this silent systemic progression that can begin decades before you ever feel the first symptom.
Decades, yeah, exactly.
And we're going to explore the precise cellular level chemical warfare we use to stop it. Because if you are looking at a patient's chart or, maybe even your own lab results, you're confronted with this alphabet soup.
Oh, the acronyms. LDL, HDL, VLDL, triglycerides. It's overwhelming.
Exactly. But the mission of this deep dive isn't to just read off a dictionary of those acronyms, right? Or just list a bunch of medications.
No, we really want to decode the intricate pharmacokinetics here.
Right. The mechanisms of action, the critical safety alerts that dictate exactly how healthcare providers wage this physiological battle in your bloodstream.
Because, I mean, treating dyslipidemia is the absolute definition of navigating diagnostic muddy waters. It's not like a fractured femur on an X-ray where you could just see the break.
Right, you can't just point to it.
Exactly. Dyslipidemia is entirely silent. A patient does not feel their low-density lipoproteins oxidizing. They don't feel them penetrating the endothelial lining of their arteries.
So because it's invisible, we're dealing with a highly complex bodily system of lipid transport and liver metabolism.
And to manage that safely, you really have to understand the why behind the medicine. You must understand how a drug is processed from the moment of administration all the way to excretion.
And the exact cellular mechanism it uses to intercept the pathology.
Right.
But before we get to those chemical interventions, we really have to establish the physiological baseline first, because dyslipidemia fundamentally acts as the precursor to atherosclerosis.
Yes, which drives myocardial ischemia, infarctions, strokes, all the major cardiac events.
Exactly. And blood lipids, so cholesterol, phospholipids, triglycerides, they are fats, which means they don't dissolve in plasma.
Right. Oil and water don't mix.
Exactly. So they require protein carriers, the lipoproteins, to travel through the systemic circulation.
And when we draw a lipid profile to assess that transport system, there is a very rigid pre-procedure protocol that stands out.
Oh, you're talking about the fasting.
Yes. The gold standard absolutely requires the patient to endure a strict 12-hour fast.
Which patients always complain about. I mean, why is that 12-hour window so critical?
Well, the necessity of that fast comes down to the behavior of triglycerides.
Yeah.
Because, while baseline cholesterol levels might remain relatively stable regardless of what you just ate, a complete lipid profile has to accurately measure triglycerides.
Okay, so what happens if I eat, a bagel right before the blood draw?
So when you consume a meal, your intestines package the dietary fats into these massive transport particles called chylomicrons.
Chylomicrons, right?
Yeah, and they just flood the bloodstream. So if a patient eats even a small meal before the blood draw, the lab equipment is essentially blinding itself with these postprandial chylomicrons.
So it's like trying to see a star during the daytime. The chylomicrons are just too bright.
That's a great way to put it. It results in an artificially massive spike in the triglyceride reading.
Wow.
So until clinical guidelines for non-fasting lipid levels are, universally standardized, that 12-hour fasting window is the only way to observe the body's true basal metabolic state.
Okay, so once we have that true basal state, when we look at those numbers, the standard adult guidelines draw some very hard lines.
Very hard lines.
Yeah, like total serum cholesterol needs to be under 200 milligrams per deciliter, and anything hitting 240 or above is entirely undesirable.
Right, 240 is a major red flag.
And then for LDL, the target is less than 130, with a 160 being the real danger zone. But HDL requires the exact opposite approach, right?
Yes, HDL is the good guy. We want that higher than 40.
But what I find clinically fascinating in the data is the threshold for an HDL of 60 milligrams per deciliter or above.
Oh, yeah. That's game changer.
It is, because it's considered so highly protective that it allows clinicians to actually subtract an entire risk factor for coronary heart disease from the patient's overall profile.
It's amazing. It functions as an active metabolic shield.
How does it actually do that, though? How does it shield the heart?
Well, it acts as a reverse transport mechanism. So it physically scavenges cholesterol from the peripheral tissues and arterial walls and then returns it to the liver for excretion.
Like a microscopic cleanup crew.
Exactly. Then, to round out the panel, we have triglycerides, where the desirable mark is strictly less than 150 milligrams per deciliter.
But applying these numbers requires a broader clinical context, doesn't it? I mean, for decades, the medical community was somewhat myopic, right?
Very much so. They focused almost exclusively on treating those fixed lab values, just trying to hit a specific number.
But the current American College of Cardiology and American Heart Association guidelines, they represent a massive paradigm shift.
They really do.
Yeah, the ACC and AHA moved away from just chasing a rigid LDL number of, like, 129. They shifted to calculating an individual's overall 10-year cardiovascular risk estimate.
Which is so much smarter, because it forces the clinician to look at the patient as a whole physiological ecosystem.
Right, because a borderline LDL level in a non-smoking normotensive patient requires a completely different intervention strategy than that exact same LDL level in someone with hypertension and diabetes.
Exactly. The overarching risk factors exponentially multiply the danger of the lipids present.
Which brings us back to why the pediatric data you mentioned at the start is so sobering.
It is. The evidence absolutely proves that atherosclerotic lesions begin in childhood.
So what are the actual guidelines for kids now?
Well, they now support selective fasting lipid screening for children as young as 2 years old, but only if there's a familial history of premature cardiovascular disease or parental dyslipidemia.
Okay, so high-risk kids get tested at 2.
Right. Furthermore, the National Heart, Lung, and Blood Institute, alongside the American Academy of Pediatrics, they actually recommend universal lipid screening for all children between 9 and 11.
Wow, universal for every kid.
Every kid, again, between 17 and 21. Because if you identify a lipoprotein disorder in 10-year-old, you have a massive window to implement modifications long before irreversible structural damage occurs to the vascular endothelium.
And those modifications, they always start with therapeutic lifestyle changes, right?
Always.
Looking at the protocols recommended in the sources, specifically the Child 1 diet for pediatric patients and the similar guidelines for adults, the clinical strictness is striking.
Yeah, it's not a casual diet.
No. They aren't just suggesting a generic eat healthy approach. They are drawing a hard line at limiting total fat to 25 to 30% of total calories.
And pushing saturated fat down to a rigid 7% for adults.
Alongside restricting dietary cholesterol to under 200 milligrams. I mean, from a clinical adherence standpoint, handing a patient those numbers requires a drastic behavioral overhaul.
It's a huge life change. They also recommend incorporating 2 grams a day of plant stanols or sterols and 10 to 25 grams of soluble fiber from things like oat bran or vegetables.
Wait, what do the plant stanols actually do? Why are they so heavily recommended?
The plant stanols and soluble fiber are highly strategic. See, plant stanols possess a molecular structure that is so similar to human cholesterol that they actually compete for the same absorption sites in the digestive tract.
Oh, so they fight for the same parking spots in the gut.
Exactly. By flooding the gut with stanols, you physically block the absorption of dietary cholesterol.
That is brilliant.
It is. And when you combine that with moderate intensity aerobic exercise, which actively raises your HDL, and weight loss, which naturally lowers LDL and triglycerides, you have a very potent non-pharmacological defense.
And I assume smoking cessation is also a massive part of that baseline defense.
Paramount. Because the chemical components of tobacco smoke actively suppress HDL synthesis, and they accelerate the oxidation of LDL.
Which is exactly what we don't want. But, we also see patients trying to manage this through alternative routes, right? The herbs and foods data specifically highlights flaxseed and flaxseed lignans as agents that can decrease LDL.
Yes, and that can be really tricky.
Because the immediate patient assumption is often, oh, I can just consume heavy amounts of flaxseed and completely bypass prescription medications.
Right, but relying on that bulk introduces a severe pharmacokinetic danger if they are already on a clinical regimen.
Wait, how so? If it's natural, why is it dangerous?
Because the mechanism by which flaxseed lowers LDL relies on heavily bulking up the gastrointestinal tract and increasing the viscosity in the gut.
Okay.
So if a patient introduces massive amounts of flaxseed while taking other medications, whether that's for hypertension, arrhythmias, glycemic control, that fibrous bulk can physically bind to or block the absorption of those critical drugs.
Oh, wow. So the flaxseed just traps the blood pressure medication and flushes it out.
Yes. The patient rapidly develops subtherapeutic plasma levels of their required medications.
Right.
So attempting to lower lipids with an unregulated supplement can accidentally neutralize their entire pharmacological safety net.
That is terrifying. Okay, so what happens when that 6-month trial of lifestyle modifications, the oat bran, the aerobic exercise, what if it all falls short?
And their 10-year ASCVD risk remains dangerously high.
Right. That's when we have to look at the primary source of the problem,
Mm.
the body's endogenous cholesterol production. We have to bring out the heavy hitters.
The statins.
Exactly.
Mm.
The HMG-CoA reductase inhibitors, universally known as statins. The prototype here is atorvastatin or Lipitor.
Right.
Because if the liver is manufacturing too much cholesterol, the strategy is to just completely shut down the assembly line.
Precisely. Atorvastatin targets the mevalonate pathway in the liver.
The mevalonate pathway. Let's break that down.
So HMG-CoA reductase is the absolute rate-limiting enzyme required for the hepatic synthesis of cholesterol. By administering a statin, we competitively inhibit this exact enzyme.
So the liver's production of cholesterol just plummets.
It does. And this triggers a secondary, highly vital mechanism. See, sensing the sudden drop in intracellular cholesterol, the liver upregulates its surface LDL receptors.
To pull circulating LDL out of the bloodstream to meet its metabolic needs.
Exactly. This dual action leads to an 18 to 55% decrease in serum LDL levels, alongside reductions in very low-density lipoproteins and triglycerides.
That is a massive drop. Now, when we look at the administration of these statins, the timing is historically very specific, right?
Very specific.
Because the bulk of endogenous cholesterol synthesis naturally operates on a circadian rhythm. It peaks while the body is fasting and sleeping at night.
Right. The liver works the night shift.
So statins are kind of like a night watchman at a factory,
Yeah.
turning off the machines while we sleep.
That's a great analogy, which is why the traditional nursing implication is to administer statins in the evening or at bedtime. You deploy the inhibitor exactly when the liver's factory is trying to ramp up production.
Now, I know atorvastatin has a long enough half-life that the time of day is a bit less critical for this specific drug, but evening administration really remains the foundational class rule.
Yes, it's best practice.
So let's trace atorvastatin's path once it is actually administered orally.
Okay, so following oral ingestion and rapid absorption in the gastrointestinal tract, atorvastatin undergoes extensive first-pass metabolism.
Meaning what exactly, for those who aren't familiar with the term?
Meaning the blood vessels absorbing the drug from the intestines do not route directly to the systemic circulation. They converge into the portal vein, which empties directly into the liver.
So the liver gets first dibs on the drug.
Exactly. The liver immediately metabolizes a massive portion of the drug before it ever reaches the rest of the body.
Doesn't that mean the systemic bioavailability is technically really low?
It does. But it is pharmacokinetically perfect, because the hepatic tissue is the exact target site where the drug needs to act.
Oh, that makes perfect sense. Delivering the drug directly to the doorstep of the problem is highly efficient. But wait, if the liver is where the drug works, isn't the liver also in danger? I mean, that places the liver under immense metabolic stress.
It absolutely does. The clinical data lists hepatic dysfunction as a severe adverse effect.
So statins are definitively contraindicated in patients with active liver disease, right?
Absolutely. Active liver disease or any unexplained elevations in liver enzymes. If you are managing a patient on atorvastatin, vigilance over hepatic function is just non-negotiable.
What's the required protocol for monitoring that?
It dictates drawing serum aminotransferases, specifically AST and ALT, before initiating therapy, and then again at 12 weeks at every subsequent dose titration and periodically thereafter.
And what's the red flag number?
If the patient's aminotransferases climb to more than 3 times the upper limit of normal and remain elevated, that signals acute hepatocellular damage.
3 times the limit. Wow.
Yeah. At that point, the statin dosage must be reduced or the drug discontinued entirely to prevent permanent hepatic injury.
But as severe as those hepatic risks are, the most limiting adverse effect of statins, the one that triggers the most immediate alarm bells for both patients and clinicians, is statin-associated muscle syndromes.
Yes. The muscle damage, it is the big one.
And this pathology ranges from myalgia, which is distinct unexplained muscle aches and weakness, right up to myositis, escalating to the life-threatening extreme of rhabdomyolysis.
Rhabdomyolysis is terrifying. It is the rapid, catastrophic breakdown of skeletal muscle tissue.
What happens when that tissue breaks down?
As the myocytes rupture, they release their intracellular contents into the systemic circulation. And the most notable one is a protein called myoglobin.
And myoglobin has to be filtered by the kidneys.
Right, but the protein molecules are simply too large, and they are heavily toxic to the renal tubules. They precipitate and physically obstruct the nephrons, leading directly to acute tubular necrosis and acute renal failure.
So the muscles break down and literally clog the kidneys.
Exactly.
And the hallmark clinical sign of this renal obstruction, the ultimate red flag you're looking for, is cola-colored urine.
Yes, it's unmistakable.
That dark, tea-like appearance is the visual evidence of myoglobin attempting to flush through the compromised kidneys.
If a patient presents with unexplained severe muscle weakness and dark urine, the statin must be held immediately and the prescriber notified.
Immediate cessation.
Yes. The risk of this muscle breakdown naturally escalates with advanced age, frailty, and high dosages. But the most severe, highly preventable trigger actually involves a breakdown in pharmacokinetics via drug interactions.
Oh, right, because atorvastatin relies heavily on the hepatic cytochrome P450 system for its metabolism and clearance.
Specifically the CYP3A4 and CYP2D6 isoenzymes.
Right, so these enzymes act as the liver's chemical processing plant, breaking the statin down for excretion.
Exactly. And the danger arises when a patient ingests substances that are potent CYP3A4 inhibitors.
Like what? What inhibits them?
Grapefruit juice is a major one. Or azole antifungals, or macrolide antibiotics like erythromycin. These physically bind to and inhibit these specific P450 enzymes.
Wait, so if the P450 processing plant is shut down by a glass of grapefruit juice, the atorvastatin has nowhere to go.
Exactly. It cannot be clear.
So the plasma concentrations of the statin skyrocket exponentially.
Yes, directly precipitating massive toxic skeletal muscle breakdown. It is a textbook, life-threatening pharmacokinetic collision.
All from grapefruit juice. That is wild.
It really is.
We also have to highlight a strict box warning regarding the cellular role of cholesterol itself, right? Because statins carry an absolute contraindication for pregnancy due to severe teratogenic risks.
Yes, this is absolutely crucial because cholesterol is a fundamental biological building block.
Right. We tend to think of it as just bad fat, but the body needs it.
It is absolutely required for the synthesis of cellular membranes, steroid hormones, and especially the development of the fetal central nervous system.
So if you introduce a potent HMG-CoA reductase inhibitor into a pregnant patient,
You systematically starve the developing fetus of the raw materials required for organogenesis and cellular division.
wow. So implementing strict birth control measures while on statin therapy is just a baseline requirement for women of childbearing age.
Absolutely non-negotiable.
Okay, so when shutting down the liver's production factory is either contraindicated or maybe it's just simply not enough to hit the required risk reduction, we have to move our focus from the hepatic system to the digestive tract.
Right. We deploy the digestive interceptors.
The bile acid sequestrants and the cholesterol absorption inhibitors. Let's start with the prototype bile acid sequestrant, which is cholestyramine.
The pharmacokinetics here are fascinating because, unlike almost every other systemic drug, cholestyramine is never actually absorbed into the bloodstream.
Wait, never. It doesn't enter the blood at all.
Not at all. It remains entirely confined within the gastrointestinal lumen and is excreted in the feces, essentially unchanged.
So how does it actually lower cholesterol if it doesn't enter the blood?
Cholestyramine operates by breaking the cycle of enterohepatic circulation.
Okay, let's break that down.
Normally, the liver synthesizes bile acids from endogenous cholesterol. These bile acids are secreted into the intestines to emulsify dietary fats. And then they are highly efficiently reabsorbed in the terminal ileum and recycled back to the liver.
So it's a closed loop. The liver makes bile, sends it to the gut sends it back.
Exactly. It's a very efficient recycling program.
But cholestyramine is administered as a powder resin that basically acts as an unabsorbable molecular sponge.
A sponge, exactly. It binds directly to the bile acids in the intestinal tract, forming an insoluble complex that the body physically cannot reabsorb.
So the sponge traps the bile, and the entire complex is just flushed out in the feces. We literally just poop out the problem.
Basically, yes.
Yeah.
And the resulting chemical chain reaction is what forces the liver's hand.
Because the hepatic tissue still requires bile acids to maintain digestive function.
Right. And with its recycled supply suddenly severed, the liver must synthesize a massive amount of new bile acids.
And to do that, it requires raw cholesterol.
Exactly. So the liver exponentially upregulates its surface LDL receptors, pulling systemic LDL cholesterol directly out of the blood plasma to fuel bile production.
That is so incredibly clever. The body tricks itself into lowering its own cholesterol.
It is. This mechanism yields a 15 to 30% reduction in serum LDL, with therapeutic effects visible within a week and maximizing around 1 month.
But sending a massive indigestible resin through the entire gastrointestinal tract has to bring a localized set of adverse effects.
Oh, heavily. The patient experiences severe abdominal fullness, flatulence, bloating, and intense constipation.
I would imagine that constipation can get pretty severe.
It frequently requires a dedicated bowel management program to prevent severe impaction. It can also cause steatorrhea, which is the excessive excretion of undigested fat in the feces due to the lack of available bile.
But the most critical nursing implication revolves around the blind nature of this molecular sponge, right? It doesn't selectively bind to just bile acids.
Not at all. It indiscriminately binds to nearly any other molecule in the GI tract.
So cholestyramine dramatically decreases the absorption of numerous critical oral medications.
Yes, digoxin, folic acid, propranolol, tetracyclines, thiazide diuretics, and oral anticoagulants like warfarin.
It simply sweeps them out of the body before they can even enter the portal circulation.
Exactly. Furthermore, by interfering with normal fat emulsification, it severely impairs the absorption of the fat-soluble vitamins A, D, E, and K.
And the disruption of vitamin K absorption immediately compromises the hepatic synthesis of clotting factors.
Right. So the patient is at a rapidly increased risk for severe bleeding tendencies, requiring vigilant assessment of their coagulation status and potential vitamin supplementation.
So to safely navigate these massive interaction risks, administration timing must be heavily guarded.
Heavily guarded. Any other medications must be administered at least 1 hour before the cholestyramine or 4 to 6 hours after.
You have to ensure the other drugs are fully absorbed before introducing the resin into the gut.
Exactly. And the physical administration of the powder also requires strict adherence to safety protocols.
Right, like can you just take it dry, like a scoop of pre-workout?
Oh, absolutely not. It must be mixed with water, soups, cereals, or high-moisture foods like applesauce. It must never be administered dry.
What happens if someone tries to swallow the dry powder?
Attempting to swallow the dry resin can cause it to rapidly expand upon contact with saliva, creating a severe, life-threatening esophageal obstruction.
It literally expands in the throat. That's horrifying.
It is. Additionally, prolonged contact with the mixture in the oral cavity can actually damage tooth enamel, so it necessitates strict dental hygiene practices post-administration.
Wow. Okay, so if the side effects of a bile acid sequestration are too disruptive or the interaction risks are too high, we have a secondary digestive interceptor, right?
We do. The cholesterol absorption inhibitors, represented by the prototype ezetimibe or Zetia.
And instead of binding bile in the intestinal lumen like a sponge, ezetimibe targets the physiological border itself.
Yes, it acts directly at the brush border of the small intestine, specifically targeting the Niemann-Pick C1-like 1 protein transport system.
That's quite a name.
It is, but by inhibiting this specific transport protein, ezetimibe physically blocks the intestinal absorption of both biliary and dietary cholesterol without acting as a blind sponge.
Oh, so crucially, this targeted mechanism does not interfere with the absorption of fat-soluble vitamins or other medications.
Exactly. It is highly specific, which makes ezetimibe an incredibly powerful synergistic agent when combined with a statin.
Because you're deploying a two-front chemical war.
Right. The statin completely shuts down the liver's endogenous production, while ezetimibe shuts the door at the jejunal enterocyte brush border, blocking any exogenous dietary compensation.
That is a phenomenal combination. But, everything we have discussed so far, the mevalonate pathway, the bile sequestrants, the brush border blocks, it's entirely focused on lowering LDL.
Yes, the bad cholesterol.
But lipid panels frequently reveal an entirely different crisis. We often see patients whose LDL is controlled, but their blood is just thick with unused caloric energy.
You're talking about severe hypertriglyceridemia.
Exactly, where serum triglycerides cross the dangerous 500 milligrams per deciliter threshold.
And at that concentration, the patient is at an imminent risk for acute pancreatitis, which is a life-threatening autoinflammation of the pancreas.
And statins will not save them here. We have to deploy a different class, the triglyceride tamers.
Right. The frontline intervention for severe hypertriglyceridemia relies on the fibrates, with the prototype being fenofibrate.
And the mechanism of action here shifts entirely away from cholesterol synthesis.
It does. Fibrates activate specific peroxisome proliferator activated receptors.
The PPAR receptors.
Yes, which exponentially increases the oxidation of fatty acids in the liver and muscle tissue.
So they basically force the body to rapidly burn through these stored fats.
Exactly. Decreasing the hepatic production of triglycerides, clearing out VLDL cholesterol, and even raising HDL levels. We see a massive 20 to 50% plummet in triglyceride levels.
But introducing fenofibrate into a patient's system requires extreme caution regarding its pharmacokinetics.
Extreme caution.
Because once administered orally, Fenofibrate is highly protein-bound in the blood, primarily aggressively attaching itself to serum albumin.
Right.
Wait, if fenofibrate is highly protein-bound to albumin, and we have a patient already stabilized on an oral anticoagulant like warfarin, which is also highly bound to albumin, we're basically setting up a microscopic game of musical chairs in the plasma, aren't we?
That is the perfect analogy.
Yes. So the fibrate enters the bloodstream, brushes the albumin, and literally physically kicks the warfarin out of the seat.
That is the exact pharmacokinetic crisis that occurs. It is one of the most dangerous safety alerts in all of lipid pharmacology.
Wow. What happens to that displaced warfarin?
When fenofibrate aggressively displaces warfarin from the albumin binding sites, the previously bound, inactive warfarin is suddenly thrust into the plasma as free drug.
And only unbound free drug is pharmacologically active.
Exactly. So the patient's system is instantly flooded with an active blood thinner, catastrophically escalating the hypoprothrombanemic effect and resulting in immediate severe bleeding hemorrhages.
That is terrifying. So if you see fenofibrate and warfarin ordered concurrently, your clinical alarm bells must be ringing.
Ringing loudly. The patient will absolutely require a substantially decreased dosage of warfarin.
Alongside rigorous daily monitoring of their coagulation labs to prevent a severe bleeding event.
Yes. You also have to assess the patient's clearance capabilities. Since fibrates are metabolized in the liver and excreted mainly by the kidneys, they will accumulate to toxic levels in patients with renal impairment.
So fenofibrate is strictly contraindicated in severe kidney disease.
Yes, and it can cause reversible elevations in serum creatinine.
We also have to monitor the biliary tract with these, right?
We do. Fibrates inherently increase the cholesterol concentration saturated within the bile.
And that supersaturation acts as the catalyst for cholelithiasis, right? The rapid formation of gallstones.
Exactly. Consequently, fibrates are contraindicated in patients with any pre-existing gallbladder disease. And the potential for hepatotoxicity also mandates careful monitoring of liver function tests throughout the first year of therapy.
Okay, so looking at the source material, it also lists niacin vitamin B3 as a miscellaneous agent for lowering high triglycerides. But clinically, niacin seems to have earned a reputation as a fallen hero.
Fallen hero is a very polite way to put it.
I mean, the theory behind it makes sense, right? It lowers triglycerides and increases HDL, but its clinical utility has completely plummeted.
Because the mechanism looks perfect on paper, but the reality of the adverse effects makes it nearly intolerable, and outcome data fails to show improved cardiovascular survival rates compared to statins.
Why is it so intolerable? It's just a vitamin.
Well, when you push niacin to the massive pharmacological doses required for dyslipidemic effects, it triggers a systemic, massive release of prostaglandins.
Specifically prostaglandin D2 and E2, right?
Yes, and these prostaglandins are highly potent vasodilators. They cause the cutaneous blood vessels to dilate rapidly.
Which explains the intense skin flushing and pruritus the text warns about.
Exactly. It's not an allergic reaction. It's a direct, unavoidable pharmacological mechanism.
Patients describe it feeling like a severe sunburn radiating from the inside out.
It's awful. Furthermore, high-dose niacin actively interferes with glucose metabolism.
Causing significant hyperglycemia.
Right, rendering it incredibly dangerous for diabetic patients whose glucose control is already compromised.
And critically, sustained release over-the-counter formulations of niacin have been directly linked to severe hepatotoxicity.
Yes. Due to this heavy burden of adverse effects and poor tolerability, it is generally reserved as an absolute last resort. You only use it for patients with triglycerides over 500 who cannot tolerate any other fibrate therapy.
Okay, so we've exhausted pills, powders, and lifestyle changes. What happens when a patient is facing a severe genetic lipid disorder, like familial hypercholesterolemia?
Or they have an absolute intolerance to statins due to severe myopathy, but their atherosclerotic risk is still critical.
Exactly. When we have exhausted the oral medications, we must turn to the cutting edge of lipid management, the injectables.
The PCSK9 inhibitors.
The prototype here is alirocumab, or Praluent. And this is entirely distinct from small molecule drugs like statins or fibrates.
It is a completely different world of medicine. Alirocumab is a fully humanized monoclonal antibody.
Engineered to target and bind to a specific regulatory protein in the liver called PCSK9.
Yes. And to understand the magnitude of this drug, we really must examine the liver's natural clearance system.
Okay, how does that work?
So, the hepatic surface is lined with receptors that act to physically grab circulating LDL particles out of the blood plasma pulling them inside the liver for degradation.
Okay, so if the liver's LDL receptors are like a fleet of garbage trucks actively clearing LDL out of the systemic circulation, what is the role of the PCSK9 protein?
The body uses the PCSK9 protein to regulate the lifespan of those garbage trucks.
How so?
Once an LDL receptor pulls a lipid particle into the liver, PCSK9 binds to the receptor and forces its intracellular degradation. It destroys the receptor so it cannot return to the surface.
Oh, so the PCSK9 protein is like the junkyard crushing the trucks to prevent overclearance.
That is exactly it. It crushes the trucks.
But in a patient with familial hypercholesterolemia, you want every single receptor functioning at maximum capacity. You don't want them degraded.
No, you need all the trucks on the road. So, alirocumab, the monoclonal antibody, binds to and completely neutralizes the PCSK9 protein.
So by inhibiting the inhibitor, the liver's receptors survive drastically longer. They continually return to the surface to clear massive, unprecedented amounts of LDL from the blood.
The drug basically shuts down the junkyard, and the clinical results are just staggering. We observe a 60 to 70% reduction in serum LDL levels.
60 to 70%. That is incredible.
It is. And because it is a large molecule biological agent, its pharmacokinetics operate completely outside the traditional hepatic CYP450 system.
Which means we completely bypass the dangerous drug interactions seen with statins?
Exactly. There is no grapefruit juice contraindication here because it never enters the P450 processing plant.
That's a huge relief. But it is administered via subcutaneous injection every 2 to 4 weeks, right?
Yes. And following injection, it absorbs slowly through the lymphatic system before reaching systemic circulation. It takes 3 to 7 days to reach maximum serum concentration.
And how is it eliminated if not through the CYP450 system?
Because it is a protein, it is eliminated through direct binding to its target,
Well,
or it's just degraded into individual amino acids through simple proteolysis.
okay. But administering a subcutaneous biologic introduces very specific nursing implications.
Highly specific. Alirocumab comes in pre-filled syringes or auto-injector pens that must be refrigerated.
But you can't inject it cold, right?
No. Before administration, the protocol strictly requires allowing the device to warm naturally to room temperature for 30 to 40 minutes.
Can you just put it in warm water to speed that up?
Absolutely not. You cannot accelerate that warming process or you risk denaturing the protein. And the subcutaneous injection itself must be administered slowly, taking a full 20 seconds to deliver the dose into the thigh, abdomen, or upper arm.
And rigorously rotating the injection sites to prevent localized tissue necrosis, I assume.
Yes. Because it is an antibody, adverse effects are generally limited to localized injection site reactions, erythema, and pain, alongside potential nasopharyngitis or flu-like immune responses.
It sounds like a miracle drug, but the true barriers with PCSK9 inhibitors are systemic and financial, aren't they?
Yes, heavily financial. These biologicals are extraordinarily expensive, frequently requiring intense pre-authorization processes.
Furthermore, because these are self-administered at home, clinical providers bear the heavy burden of expensive patient education.
Right. You have to ensure the patient demonstrates flawless aseptic subcutaneous injection technique.
They have to understand the warming protocols and adhere to strict safety guidelines regarding puncture-resistant sharps disposal to prevent environmental biohazards.
It's a lot of responsibility to put on the patient.
It really is. Now, managing dyslipidemia in the real world rarely relies on a single agent. The disease process is deeply stubborn, requiring healthcare providers to mix and match these pharmacological weapons.
Right. The master class in management relies on understanding the cellular synergies and, more importantly, the catastrophic danger zones.
We already touched on the brilliant synergy of combining a statin with ezetimibe, or a bile acid sequestrant, striking both hepatic synthesis and intestinal absorption simultaneously.
Yes, attacking from two sides.
But we have to synthesize the absolute red flags, the danger zones.
The most dangerous combination a clinician can authorize is a statin combined with a fibrate.
Because both classes independently carry the risk of severe skeletal muscle damage.
Exactly. Administering them concurrently creates a massive synergistic compounding of that risk.
Yeah.
It drastically accelerates the onset of severe myopathy and renal clogging rhabdomyolysis.
And similarly, combining a statin with niacin layers, two highly hepatotoxic agents on top of each other, exponentially increasing the risk of acute liver failure.
Another massive red flag.
So if a patient falls into one of these toxic cascades, if their urine turns the color of cola or their aminotransferases spike 4 times above the baseline, What is the pharmacological rescue?
The rescue.
Yeah, like if a patient overdoses on an opioid, we push naloxone. If they bleed out on warfarin, we push vitamin K. What is the precise antidote we administer to neutralize a statin or a fibrate in the bloodstream?
Oh, there is absolutely no antidote.
Wait, none?
None. There is no pharmacological reversal agent for any of the dyslipidemic classes.
Okay.
You cannot instantly neutralize these molecules once they are bound to their enzymatic targets or circulating in the plasma.
Wow. That reality forces a massive shift in clinical responsibility.
It does. If there is no antidote, the protocol for adverse effects relies entirely on rapid detection and immediate cessation.
You hold the drug?
You hold the drug,
Yeah.
you notify the prescriber, you initiate aggressive supportive care like massive IV fluid hydration to force the myoglobin through the renal tubules in the case of rhabdo,
Yeah.
and then you simply have to wait.
Wait for the hepatic and renal systems to clear the drug based entirely on its physiological half-life.
Yes, that underscores the single most vital nursing implication for lipid management: vigilance over the organs that process the drugs.
Because you are fundamentally altering hepatic metabolism and renal excretion.
You must monitor the aminotransferases, you must track creatinine clearance, you must rigorously investigate any report of unexplained muscle pain.
And fundamentally, you must continuously reassess the patient's dietary adherence.
Oh, absolutely. The physiological reality is that caloric surplus and weight gain will entirely override the lipid-lowering capabilities of these drugs.
You cannot pharmacologically outpace a poor diet.
Never.
We have dissected the exact strategies used to clear the murky waters of a lipid profile today.
We really have.
We've explored the cellular blockade of the mevalonate pathway with statins, the mechanical disruption of the enterohepatic cycle with cholestyramine, the brush border shutdown by ezetimibe.
The targeted fatty acid oxidation of the fibrates, and the biological rescue of the LDL receptors via PCSK9 inhibition.
It's incredible. If you look at a patient's medication list now, you aren't just reading names. You are witnessing a multi-front chemical war being waged to protect the vascular endothelium.
And the physiological complexity of that war brings us back to a profound point hidden in the pediatric guidelines we talked about earlier.
Right.
The clinical confirmation that atherosclerotic lesions, the physical hardening of the arteries, begin taking root in the vasculature of young children.
We are no longer waiting for 50-year-olds to present with angina.
No. By implementing universal lipid screening at age 9, identifying high-risk dyslipidemias, and deploying these precise cellular interventions decades earlier than ever before in medical history.
We are fundamentally intercepting the primary driver of global mortality.
Exactly. And it leaves you wondering, how entirely will that early interdiction reshape human longevity and cardiovascular pathology in the coming century?
It transforms the field from reactive disease management to true cellular-level prevention before the vascular damage even begins.
It changes the entire landscape of human health.
Thank you for joining us on this deep dive into the source material. Keep questioning the why behind the cellular mechanisms. Keep looking for the physiological reasoning behind the lab numbers. And remember, even when the diagnostic landscape feels totally silent and the X-ray machine is useless, the science of the human body is always working to clear the waters. Catch you next time.